So thanks for taking time to come and talk about Cushing's. It's something that is hopefully an exciting, therapeutic area with two new medications coming to the marketplace. And we wanted to take the opportunity to present some information about Korlym. So one of the reasons that we think that Korlym is important is because with current therapies, it's really difficult to achieve significant clinical improvement as well as normalization of cortisol levels when patients have failed surgery or surgery is not a good option. So surgery is clearly the best option when an adenoma can be identified and can be surgically removed. But when that's not the case, or when that doesn't work well for a patient, finding other options to control the cortisol levels and normalize the cortisol levels and get good clinical control is not something that seems to work very well. And what Korlym does is it offers a novel and effective approach, and by blocking the glucocorticoid receptor, which is the primary target of excess cortisol, it's a very effective method of treating the clinical consequences of Cushing's syndrome. So it's a sort of a new way to think about how to treat these patients, since cortisol levels are very difficult to normalize. Now, receptor blockade is a well-established mechanism. It's used to treat a wide range of diseases. You all, as endocrinologists, are probably very familiar with using pegvisomant in acromegaly, or using a mineralocorticoid blocker for the treatment of primary hyperaldosteronism. In primary hyperaldosteronism, you don't try to control the level of aldosterone. You actually use a mineralocorticoid blocker to block its effect. And Korlym is very similar to these types of approaches in terms of treatment of patients with Cushing's syndrome. So the way Korlym works is that in Cushing's syndrome, obviously there's excess cortisol, and that excess cortisol, which is represented by the heavier arrow, stimulates excessively the glucocorticoid receptor, and in some cases, depending upon cortisol levels in the patient, can actually provide additional MR stimulation as well. Now, what Korlym does in patients with Cushing's syndrome is that it competitively blocks the glucocorticoid receptor, so blocking the primary hyperactivity at the glucocorticoid receptor that happens as a result of high cortisol levels. It does not, however, block the mineralocorticoid receptor. So in some patients, again, dependent on cortisol levels, patients may have additional and extra stimulation of the mineralocorticoid receptor from cortisol. Any questions about the mechanism? Now, what this glucocorticoid receptor blockade does with Korlym is it effectively treats the clinical consequences of Cushing's syndrome. The most important of those being the improvements in the patient's metabolic profile. The metabolic disease is what leads to these patients having significant morbidity and mortality over time. So the primary thing you want to ensure that you do is to be able to improve the metabolic profile. And with Korlym, you'll see in the data, lowers glucose levels, lowers A1C over time, reduces the amount of diabetes medicines that the patient would need to take as a result of those improvements. Also, their patients lose weight and they lose it around the middle, which is where you'd like to see these patients lose it. But it's not all about the metabolic profile in patients with Cushing's syndrome. You would also hope to see improvements in a whole range of other things, like the Cushingoid appearance and body habitus that these patients take on, things like stria, for instance, and improvements in psychiatric symptoms like mood and cognition, etc. Now, specifically looking at the numbers, the percent of patients that responded with a decrease in glucose, 60% of patients responded with a 25% reduction in the area under the curve glucose. And not only did you see this, but you actually see it very rapidly. So patients on Korlym who do have hyperglycemia do see a rapid reduction, and in fact, you can see that the second line, the second lower line, it represents the glucose levels at 6 weeks, which are significantly less than they were at baseline. So the drug in these types of patients happens to work very rapidly. But you also want to see that this glucose control is held over time, and you would measure that by A1C, obviously, and you can see that in patients with diabetes on Korlym, a significant reduction in A1C of about 1.1%, and for those that had abnormally high baseline A1Cs greater than or equal to 7, the mean reduction was actually about 2.2% just after 6 months. And as you would hope to see, you see patients take less medications, anti-diabetic medications specifically. So there were about 12 patients in the trial that were on insulin. 7 of those patients had a reduction in insulin levels. In fact, 2 patients came off altogether. The baseline insulin dose was 88 units, and by the end of the trial, it was actually, in those 12 patients, the median dose was 55 units. But you'd also hope to see these improvements in the metabolic profile happen over time beyond just the glucose parameters, and you see a significant amount of weight loss. Patients that stayed on the drug for the full 6-month trial lost nearly 8% of their body weight. And I think it's also important to point out that these patients didn't look like that the weight loss had stopped at 6 months either. So I think that it would be reasonable to suggest that there may be further weight loss beyond the 6-month period of time.
What's the last time point? W2418?
Yeah, so there were a handful of patients that did not complete the full trial. So if they were on the drug for a month but did not finish the 6 months, they were included in that data point. So including all of those early terminations, it is about 6% weight loss. And these patients also lose their weight around the middle, and you can see that the waist circumference for women decreased by about 7 centimeters and 9 centimeters in men, which was a significant amount, and the men lost a little bit more because they were likely a little bit larger at the beginning. But the signs and symptoms of Cushing's syndrome are not just the metabolic profile, as I talked about before. It does include other things like dystria, Cushingoid appearance, and psychiatric and cognitive disturbances. And as was reported in the publication in JCEM, as you can see in the boxed data, that 87% of patients had an overall global clinical improvement as identified by a data review board of 3 experts that were blinded to the actual patients. But just looking at the data, looking at pictures, etc., they were able to determine that there was global clinical improvement beyond just the glucose parameters that we already went over. One of those things that went into this, just as a for instance, is the change in depression scores. So using the Beck Depression Inventory, you can see that there were 25 patients who at baseline were depressed. And by the end of the trial, these 25 patients, on average, were no longer depressed at the end of the trial. So that's just one example of the types of things that go into the score that show the 87% global clinical improvement. So any questions based upon the data that I've gone over so far? Okay. There were adverse events that you need to be aware of. The most commonly reported adverse events were nausea, fatigue, headache, and arthralgias. And I would suggest that these are sort of the side effects of effectively treating a patient for Cushing's syndrome. That when you've been on a cortisol high for a long time and you withdraw from that effect by blocking the glucocorticoid receptor, in this case that you're going to see these types of treatment effects. There are other adverse events of note. Hypokalemia happened in about a third of patients, and I mentioned before that it does not block the mineralocorticoid receptor, and because there can be additional activation of the mineralocorticoid receptor from the high cortisol levels, these patients can be hypokalemic, either in a baseline state from Cushing's or in addition to the Korlym treatment. And then patients can also have, female patients obviously can have endometrial thickening because of the fact that it does block the progesterone receptor as well. And there were a couple of patients who were reported by the investigators as having signs of adrenal insufficiency, but neither of these patients had hypotension or hypoglycemia as part of that event. Any particular concerns that you would have about this medicine from what we've talked about?
Well, it appears that half of the patients have either nausea, headaches, or fatigue. I mean, how severe and chronic are the symptoms? Is this just transient symptoms that patients experienced, or they were ongoing during the 6 months trial? And how many patients dropped out because of the symptoms?
So there were a total number of dropouts in the trial. So they started with 50, and then 17 patients dropped out for a variety of different reasons. There was no single sort of event that led to those dropouts. Fatigue might have been one of the things that was, more prevalent amongst that group. And some of that happened very early on, when they first started taking the medication and they just didn't like the fatigue feeling. Probably similar to how patients might feel after a surgery or when they're weaning off of steroids. So I think the level of severity is probably very patient dependent, and it's one of the things that you pay attention to as you're titrating the medication. With this medicine, you start at 300 milligrams, and you would titrate up by 300 milligrams every 4 to 6 weeks, dependent upon how the patient is doing. So you would look for, if a patient was really, really fatigued, it might not be the right time to bump their dose, and you just have to pay attention to that as you're making the patient-specific choices.
And are these symptoms only transient, or are there some patients that continuously have these symptoms? Because after successful surgery, for example, yes, you do have these symptoms, but it's very transient.
Yeah. From what I understand, patients are more likely to have them early on, and when you titrate, and then it transient sort of after that. But I would imagine that there are some patients where you get to, you might go to, let's say, get to a dose of 900 milligrams, and for that patient, 900 milligrams just might be too much. And then you would probably, so if those symptoms persisted in a way that the patient couldn't tolerate it, then you would, perhaps back them back down to 600 milligrams. So it's one of the good things about this drug is that it is titratable, so you can titrate to the effect that you're looking for.
I think the issue is, though, are these side effects because you're reducing a high cortisol effect, or is it a side effect because it's adrenal insufficiency? I mean, that's the big question, and that's what is kind of hard to know with Korlym. I mean, after surgery, you expect to see all those symptoms, and you expect, if you're lucky, that they achieve remission, will have very low cortisol, but you're replacing them with hydrocortisone, so you can just, adjust the dose and then taper down once they're ready. I mean, with this, the issue is you don't know if it's just they're going from too much to normal or too much to too little. That's kind of hard to know, I think.
And is that paradigm similar to when you're weaning a patient off of steroids?
But yeah, I mean, when you're weaning them off, you know that you're giving them physiologic or super physiologic doses of hydrocortisone, so you know that they have enough to survive and get by, and you can tell them, you can address some of the symptoms with other things that might help, like an anti-inflammatory, or go up on the dose if you need to. But you wouldn't really taper down or taper off the hydrocortisone until they had a normal cortisol. So you kind of know, that they're going to have the symptoms, but you also know you're replacing
Right.
their cortisol. So I think that's the difference.
Okay. Well, so let's actually talk about a few more things related to the mechanism of action. Just get a little bit deeper into it and see if this raises some additional, ideas or points for you. So, in a normal patient, without any disease at all, cortisol is the primary activator of the glucocorticoid receptor, and in certain tissues specifically that manage sodium, aldosterone is the primary activator of MR. Cortisol does also activate MR in a lot of other tissues, but we're going to kind of leave that to the side for now. And through this sort of balance of cortisol and aldosterone activating these two receptors, you get a balanced sort of cardiorenal effects where cortisol and GR is having an effect on vasoconstriction and vasodilation, so acting at sort of the vessel level. And then aldosterone in its activation of the mineralocorticoid receptor is essentially helping to balance the volume, right, through the movement of sodium and potassium. And in a healthy patient, these things are balanced, and the patient's cardiorenal picture is healthy, and blood pressure is in a normal range. In Cushing's syndrome, patients have, because of high cortisol, they have excessive stimulation of the GR receptor, the glucocorticoid receptor, and potentially excessive activation of the mineralocorticoid receptor. Both of these things tend to drive blood pressure up. So an increase in vasoconstriction and an increase in volume, you have two mechanisms that are leading to the blood pressure going up. Now, this is very different than, for instance, Addison's disease, so primary adrenal insufficiency. And this is kind of the reason I want to talk about this is to understand how the effect of Korlym works being very different than what would be the case with a primary adrenal insufficiency or adrenal crisis. So in Addison's disease, there's very low or no cortisol because the adrenal glands aren't working, and or they don't have adrenal glands, and there's very low or no mineralocorticoid as well. So you get no activation or low activation of both the glucocorticoid receptor and the mineralocorticoid receptor. So opposite of Cushing syndrome, you've got patients that have a negative effect on vasoconstriction and a negative effect on volume, both things that are leading to blood pressure being driven down. And this is what happens when patients have adrenal crisis, or the type of adrenal insufficiency that you would be nervous about patients, essentially falling over and crashing. Now, this is distinctly different than how Korlym works. Korlym only blocks the glucocorticoid receptor, and it does not block the mineralocorticoid receptor. In fact, different than Addison's disease, where there's no cortisol around. In the case of Cushing syndrome with mifepristone, there's lots of cortisol around. Right? And because there's lots of cortisol around, you have even excessive stimulation in many cases to the mineralocorticoid receptor, which is one of the reasons why there's a tendency for hypokalemia to happen. So does the fact that it does not block the mineralocorticoid receptor and only blocks the glucocorticoid receptor, does that have an impact on how you think about these patients and their symptoms around adrenal insufficiency?
Not really, because patients that have pituitary Cushing's that usually supposedly have normal mineralocorticoid production by the adrenal gland, they can still crash, meaning developing cardiovascular collapse. Because it's not so much that it's primarily mineralocorticoid receptor activity that then allows you to maintain blood pressure, but it seems that glucocorticoid receptor signaling is a permissive factor for catecholamines to work. And so you're taking that away. So there's a concern that if patients get really sick and end up being septic, for example, that then you still end up crashing, despite the fact that cortisol levels are high and signaling through the mineralocorticoid receptor is still intact. So I'm not convinced about that.
And you mentioned something there at the end that I thought was, I want to draw a distinction. You said a patient, for instance, that gets septic. So are you talking about patients that only in a time where they have excessive stress that might lead to a time where a patient could crash?
Yeah,
or?
I think so. I think, that's always a major concern that we face when we are replacing hydrocortisone in patients with adrenal insufficiency, right? That their requirements change as they encounter stress. Now, that doesn't necessarily mean major infection, right? That could be psychological, it could be being involved in a car accident, and so forth. I mean, as
trauma, the flu.
Right, and then your requirements go up, right? And go up very quickly, right? And so, I guess most of the time we have the time to then scale down the dose, right?
Right.
But let's say that doesn't happen, or the patient, as does happen, doesn't really realize that he or she is sliding into a stressful situation and just continues to take that. And so I think this is a concern. What do you think?
Yeah, I think, if anything, this excessive stimulation of the mineralocorticoid receptor, you're getting more stimulation because cortisol levels are going up as you block the receptors. So it's not just high, but if they become higher, and there's excessive stimulation, so they're sort of on the flip side, there's a concern of, agonism of the mineralocorticoid receptor is now considered to be its own cardiovascular risk factor, and what are the effects of that? So that's sort of a separate concern. But in terms of the adrenal insufficiency issue and getting sick, and that's a little bit. It is. I think it is concerning because how do you stress dose these people when they get sick? What doses? What we know that if someone has adrenal insufficiency and you tell them they have an injectable form at home of 100 milligrams of hydrocortisone or 4 milligrams of dexamethasone or whatever it is, that's going to be enough. But how do you know what's going to be enough in this setting? And I think, it's an interesting point. I think because my focus is really pituitary Cushing's, that I'm always dealing with intact mineralocorticoid activity. You're not dealing with, unless the patients who then go on to require bilateral adrenalectomy, those ones obviously, need mineralocorticoid replacement. But at least in the model that I see most frequently, which is pituitary Cushing's, the model is one that includes intact aldosterone anyway.
Right.
So.
And is it your experience that outside of the initial surgery where the HPA axis is so disrupted that a patient sort of crashing is sort of the same thing as like an Addisonian type of event?
It's not that, it's pretty rare. You have to always educate the patient. You have to tell them about stress doses when they're sick. You have to make sure they have, really technically they should have an injectable form at home. They should wear a medical alert bracelet. And you're not ever really sure, even after, there's a period, even after you fully stop hydrocortisone, there's a period of relative adrenal insufficiency. And, these patients could require hydrocortisone for a year or more. So there's a long period that you have to be, aware of that. But there is this idea that it's transient and, so there's I think there's less focus on that compared to someone who has really permanent adrenal insufficiency, who really, but they do need all that education. But I mean, in reality, I don't see it that much that they have an adrenal crisis.
Right. So it sounds like a very similar thing with that. The use of Korlym fits right in with that, the same paradigm. That
Probably the concern is more than the reality, but the difference is what dose and how do you stress dose them to overcome that blockade? Like how much is enough to overcome the blockade in the stressful?
What is the half-life of the drug?
It's long. It's between, I think it's like 65 hours. I think is the right number.
So if they discontinue, let's say if they get really sick and they discontinue the drug, so you're talking about 3-4 days or longer of the blockade.
Right.
So
that
if they
really
get
is the
critically
time
ill,
that patients
Right.
slide into it.
Yeah, so you would want, if you had a patient who did have trauma, like you mentioned, and you might have to give dexamethasone for a few days.
right.
Right. I mean, it does happen. Yes, it may be
Sure it does.
rare, and all our. I mean, even Eliza that treats so many patients. I mean, after all, what is 60, 80
Yeah.
patients, right? So if you read the textbook, right, the textbook is very clear. If you have pituitary secondary adrenal insufficiency, right, there would be comparable to that, right? You have to assume that you have to treat that adequately, and if you don't, then the patient can crash and patients can die, and there are hundreds of case reports like that, and there are reviews on that. And even if you just lack ACTH deficiency, right, isolated ACTH deficiency, a patient can crash. Okay? And so it really is a concern because we don't really know how to deal with that, right? So what is then an adequate dexamethasone dose? What is it? 100 milligrams?
From what I understand, 4 milligrams per 300 milligrams of.
Well, how was that assessed?
That's been through. That's through experience. That's not something that's in the label, as I understand it, but it's something that is through experiences in using medication with dexamethasone. So, what I would suggest is that it's using Korlym is doesn't come. You don't use the drug and then turn your back, and you can't do that. You have to be vigilant. As you would have to be vigilant with any of these patients. I mean, I think what it comes down to is that effectively treating Cushing syndrome, it's hard. It's hard when you do it well, and it's hard when you have trouble doing it well. In either case, and you're not going to be able to use Korlym and turn your back, just like you wouldn't give a patient a transthyreal surgery and then just give them their steroids and turn your back. Same idea. It's not the same exact thing, but it's the same idea.
Yeah, but it is a specific issue that this drug raises, right? And plus you lack a biological readout really that drives the dose, and it's often very diffuse, right? That you look at clinical signs, but a lot of time, if then there are other conditions, it's really hard to judge.
I think that's the bias of the endocrinologist. I mean, another argument can be when you treat depression, you're not looking at numbers, you're looking at how the patient does. And when you give spironolactone, which you're talking about, blocker, or the MR, you're just seeing how the patient does. I mean, there's lots of situations where you just have to, follow clinical response. But I think we're very focused on the numbers, and particularly with Cushing's, and the irony is the numbers don't always correlate to the clinical situation of the patient, and that occurs at presentation too. You can have very high numbers, but clinically not that Cushingoid, and you can have the opposite where the numbers aren't that high and they are very Cushingoid. But I do think that is the main concern with the medication that most endocrinologists will have, is the risk for adrenal insufficiency and this concern of what do you go by, and that's a big bias. I mean, that's a big issue.
So I'll just, go ahead.
And, unopposed mineralocorticoid receptor stimulation, what it's going to do in terms of morbidity and mortality. I think we need some data over the course of 5 years to see what happens, and whether there has to be some mineralocorticoid receptor blockade as well, additionally to glucocorticoid receptors, so not to have this unopposed stimulation. So that's especially in patients who have the hypertensive response.
Yeah, and there were patients in the clinical trial that did get a mineralocorticoid blocker as part of a way of helping to control their low potassium levels.
Okay.
Thank you.
Yeah, sure.